Welcome to Seminar 8 in the Brain and Mind Centre Youth Model seminar series. My name is Associate Professor Elizabeth Scott. I am the Director of the Young Adult Mental Health Unit at the St Vincent's Private Hospital in Sydney, and I'm a clinical academic at the University of Sydney Brain and Mind Centre and at the University of Notre Dame in Sydney. This episode continues our discussion of circadian-based mood disorders in bipolar disorder and atypical depression, and looks at the application of the youth model in the treatment, in the assessment and treatments of these disorders. And we'll follow on from the case example that we saw in Seminar 7. And before I start, I would like to acknowledge the traditional owners of the land on which the University of Sydney stands, the Gadigal people of the Eora Nation, and pay respects to their elders past and present, and acknowledge their contribution in their understanding and knowledge of working in partnerships to improve the well-being of people in the community. I'd also like to acknowledge our community of young people with lived experience and their families, without whom this education series would not be possible. I'm going to describe in the overview in this episode the assessment and the establishment of routine outcome monitoring in practice, look at evidence-based and personalised care, particularly relating to both non-pharmacological and pharmacological interventions, and follow up on the case example of atypical depression that we saw in the previous episode. Before we start, I'd just like to talk a little bit about personalising treatment and monitoring outcomes in young people in these disorders. We'd always assumed, I think there'd be general assumption, that sleep disturbance in depression and anxiety was a secondary phenomenon. People got depressed, they got anxious, and therefore they couldn't sleep. The assumption in the circadian-based disorders is the opposite. It is actually that it is the fundamental disruption of the sleep-wake cycle and circadian rhythm that underpins and drives the depression in these disorders. And that allows us to develop some specific measures and ways of tracking outcomes for the first time in psychiatry that relate to the underlying physiology, pathophysiology of the disorder. And allows us then to look at specific behavioural and pharmacological strategies that target these basic regulatory systems, and to develop the objective tests of sleep-wake cycle and circadian function, those that measure the timing, the synchrony of circadian-dependent physiology, as well as daytime activity and nighttime sleep patterns, so that allow us to identify this subclass of circadian patients with major depression, and to be able to track the effectiveness of the treatment interventions that we use to try and restabilize these sleep systems. The development of biomarkers and the application of these in practice. So we're going to talk about the middle group here of circadian fatigue and depression, and look at the ways of assessment, the interventions, but particularly look at those things, the measures that enable us to identify these disorders and to track progress over time. And in particular in our practice, the use of actigraphy and dim light melatonin assay. Actigraphy watches are not attractive, as you can see from this picture. The Apple watches, those commercial watches, are obviously much prettier and much fancier, but nowhere near as sensitive as the specifically designed actigraphy watches that have a very sophisticated accelerometer. These watches allow you to look at patterns of physical activity as well as sleep over 24-hour periods. In our practice, we use 2 weeks of recording, and this helps to differentiate between weekends and weekdays, particularly important for those young people who are at school. It looks at variability in daily patterns. They allow us to sequence the relationships between mood and cognition in relation to sleep and activity patterns, and look at physical health outcomes using quite specific analytical systems. It also allows us to look at the relationships of sleep and activity patterns with body temperature and light exposure to be able to see some of the physiology of these disorders. This is an actigraphy, an actigraph from actigraphy from a young patient who has bipolar disorder, and he is in his depressed phase. And what you can see here is that he is going to bed very late in the early hours of the morning. So he's got a phase delay in terms of his sleep. He's getting up very late, so his waking times are often quite late, and his overall sleep pattern is extremely disturbed. So he's late rising, he's got poor sleep regularity, he's got a lot of disturbed sleep. His activity patterns, which you can see with these kind of black spiky patterns, are fairly limited. He's got big gaps in his day, so he's got lower total activity than expected. Here's a young person who has a seasonal onset of hypomania, mania, usually around the Easter period, around March, April. And when he tracks his sleep and activity patterns, you can see that as he approaches this time of year, if he's going to relapse into an episode, you can start to see that his sleep becomes shorter, that his activity patterns start to become much greater. And you can see that before there is any change in mood. So you can start to see the early warning signs of relapse before there is a change in mood, which enables an early intervention to help prevent relapse. So what do we do? How do you maximize your 24-hour body clock to improve your sense of well-being? So relevant to all of us, what are the things that we can do that actually, particularly in this kind of COVID era, that actually help us feel better and have better sleep and energy patterns? And the answer to that, if you think about the sleep-wake cycle and the body clock and how it is regulated by light exposure, then getting up in the morning and being exposed to light is one of the kind of critical steps. And that means getting outside, walking, getting on your bike, getting outside and being active in the morning. So getting morning sunlight helps to suppress melatonin. It raises your body temperature. It helps you feel awake and alert, increases your heart rate, which makes you feel more able to exercise. Going out in the afternoon when people often feel quite tired, want to have a siesta, helps you stabilize your sleep patterns, helps you improve your energy over the afternoon. And being active rather than sedentary overall improves your metabolism, helps to regulate your eating and your weight. So what we say to people is get up, get outside, feel more awake. That helps you get to sleep at night. The earlier you get up in the morning, the more likely it is you're going to get to bed at a reasonable time, and it's going to make you feel more awake and energetic for the day ahead. And if you are in a low mood, if you're in one of these seasonal mood patterns where you feel like hibernating, then it is the first step in terms of helping people get out of hibernation to be able to feel more awake and alert during the day. There's a whole set of psychoeducation that's been developed by the Brain and Mind Center that you can see on the website that helps to explain to people about how to restore your sleep-wake and circadian cycle. What's the biology of that? How to do it in practice? What are the consequences in terms of physiology or your physical health and your behavior? How sleep is important for concentration, reaction time, for driving, for being able to get up in the morning and sit an exam or go to work. How to do that in practice? How to actually schedule activities across the course of the day, getting up early, getting outside, setting physical activity and then cognitive activity, making sure that you don't nap during the day, that you eat at regular times, that you don't drink caffeine, that you try and avoid taking sedatives at night, that you get into bed, that you wind down, reduce light exposure, you get to bed, and what that does in terms of your physiology, your hormonal system, your body temperature, your cortisol, and your melatonin system. So to provide education that explains why these interventions are really important and effective, and that can be easily done at home with support from family or friends or carers. So the Americans, Alan Frank, have called this interpersonal and social rhythms therapy. We call it circadian therapy. It's essentially the same. That involves the usual, not just sleep hygiene and setting regular sleep onset and offset times, but eating at regular times, thinking about your social rhythms, getting up getting out of bed, and being social as early as possible during the day. Trying to minimize overstimulation, pace your activity, avoid staying up late, multiple events, social overload. But in times where people are underactive, using behavioral activation to address understimulation, plan and engage in activities that are pleasurable. If you can't get pleasure from them, at least give you a sense of achievement or mastery. Set small goals that are achievable with this stepwise progression, and identify interpersonal sources of support that will help you stabilize your circadian rhythms and avoid those people, maybe those ones who are going out late and drinking or using drugs, who are going to disrupt it. Take medication at regular times so you develop this regular synchronized pattern of activity, and importantly, or most importantly, track activity and progress over time so that you maintain these rhythms and you can see where they start to become disrupted. That can be tracked using a simple mood diary. We used to do it on paper. Now there are multiple apps or systems online that allow you to track this. I have patients who do this online through an app on their phone, and then they send it to me on a regular basis before their appointment. So I can see exactly what their sleep, their activity patterns, and in the comments that they provide, what are the things that may be driving low mood or disrupted sleep? What helps, what doesn't help? That allows people to develop the self-management skills that they need over time. You can then monitor these daily symptoms in quite complex systems over time on a week-to-week basis. This one is from a biploar mood monitoring system where you can monitor symptoms of mania, hyperactivity, activation, depression, and function on a week-by-week basis. So again, you can start to track progress over time. There are many great apps now available for doing this. It's good to see the ones that you like to use in practice, develop familiarity with that, maybe use them yourselves so you understand how to use them. But there are some great apps. I use iMood Journal for people monitoring their mood, and there are great simple apps that you can use on iPhones, Sleepio, for instance. But there are many that have been rated and can tell you how likely it is that people will use them and continue to use them over time. Fitbit and simple activity trackers that are commercially available are now very cheap, that are now to have real-time measurement-based care of these specific syndromes, so that we now can develop both personalized care that is important to that person and their sleep and activity patterns and their mood and their lifestyle, the factors that are important to them, using measurement-based, and to be able to track that over time so that you can see if somebody is thriving or that they are on the verge of relapse or they have relapsed, so that you can then provide the right intervention, the right care at the right time. So in our multimodal assessment, this means that in addition to providing the treatments of these mood disorders that are likely to improve symptoms, the syndrome, we can also look at how physical activity, and this particularly applies to circadian-based disorders, how physical activity, harm minimization, managing self-harm, suicidal thoughts or impulsivity, managing alcohol and other substance abuse, interacts with the actual symptom progression over time. And interventions like employment support and placement that provide the scaffolding for circadian systems, enable people to go to bed at night, get up in the morning and interact with people in a regular way. Again, how much they impact on symptoms and outcomes over time. So again, this multimodal assessment, and then to be able to track the effects of those interventions over time across the course of the person's illness. So to using the trajectory model, looking at stage of illness, again to see in these circadian-based disorders how different interventions, those that might be helpful to the whole population around sleep and activity patterns and well-being, how interventions might be relevant at early stages of illness, and being able to track whether people are improving or whether they are going on to more severe stage 1B disorders and what interventions they might need, tracking people's recovery or their transition into more severe disorders and providing the interventions to get people back on track again, and then being able to monitor recovery and to see early indicators of relapse. So this measurement, personalised and measurement-based care using technology allows us from the initial assessment and first appointment to implement measurement-based care, use systems such as activity trackers connected to a system allowing us to track sleep and activity, to be able to devise treatment plans, assess whether that's working, and to be able to follow over time to be able to track people up to recovery and allow them to self-monitor themselves to be able to develop the skills to manage their illness and to seek help again when that is required. So in terms of circadian-based therapy, the aim is to either look at the period of sleep, look at the phase of sleep, particularly if it's phase delayed, to be able to phase advanced sleep, to stabilize rhythms, and to employ the multimodal assessment strategies that we've discussed. In addition to that, to look at the specific measures like actigraphy, like the metabolic, hormonal, inflammatory screens that are relevant to these disorders, given the interaction of our brain clock, which we talked about, with those, with all our body clocks, which make the circadian-based disorders have much higher correlation with metabolic syndrome, hormonal disorders like endometriosis, PCOS, and immune inflammatory disorders, which we see in much greater numbers than you see in other types of depression. The psychological therapies, which are based around specifically for these disorders, based around behavioral regulation, around light exposure, physical activity and exercise, online or ICBT for insomnia, which is now very accessible through programs like This Way Up, mindfulness-based CBT to minimize stress and help stabilize sleep systems during periods of increased psychological stress, melatonin and their analogues in terms of pharmacological therapies and their impact on sleep, the orexin antagonists. Orexin systems keep you awake during the day. If you can't turn these systems off at night, then you can't sleep properly despite your melatonin system. So the orexin antagonist, suvorexin, helps to turn orexin systems off at night, can help to stabilize sleep systems. And then the rhythm stabilization using bright light therapy and traditional agents like lithium. And then to look at how you sequence those treatments in real time. So in terms of, just to summarize, the psychological and the pharmacological treatment options, psychological and behavioral therapies aimed at maintaining stable sleep, regular exercise and activity patterns, reduce and managing anxiety and stress, to reduce rumination, improve self-esteem, manage emotional regulation skills, minimize substance use, improve impulse control, and help people get back to work and study. The pharmacological therapy, which aims at improving and stabilizing mood using antidepressants and mood stabilizers, prevention of relapse, and minimizing metabolic disturbance using agents such as lamotrigine and aripiprazole, which have better metabolic profiles. In terms of scheduling therapy, you can then develop a schedule based on what interventions are likely to be relevant at different times. But across all of these stages of illness, the circadian rhythm and sleep-wake cycle therapy are going to be important for people with circadian disorders, bipolar disorder, seasonal affective disorder, or atypical depression. And then looking stepwise at what are the other interventions that you would add at different stages of illness. And the therapies going from simple melatonin-based therapies or fish oils through to more significant antidepressant therapy, being taken care with how you choose different antidepressants, particularly in bipolar disorder, and then mood stabilizers. Bright light therapy is something that has been around for a long time. When I worked at the Mood Disorders Unit, we had huge halogen lights that would shine on people to provide light therapy. Now it's done in much more subtle ways with light boxes, glasses, or caps that provide the light exposure. And bright light therapy has been used in a range of depressive disorders, but again, particularly in bipolar type disorders, atypical disorders, seasonal affective disorder, to help resynchronize the biological clock, improve alertness, change sleep, the synchrony of sleep, and impact on serotonin, potentially, theoretically impact on the serotonin and monoaminergic pathways that then help to promote positive mood and manage depression. Pharmacological agents, as we've discussed, focus on melatonin in terms of sleep onset and offset and the stability of sleep, noting that it's not an antidepressant. It's been shown not to have antidepressant activity, as opposed to agomelatine, which is a melatonin agonist on MT1 and MT2 receptors and an antagonist at 5-HT2C receptors, giving it its antidepressant activity, helps resynchronize circadian rhythms in patients with depression, in addition to treating their depressed mood. Lithium, an old drug, which we've often struggled to understand exactly how it works, but it has been shown to work on circadian systems. It lengthens the period and has inter-episode effects. Other agents, stimulants, and other vigilance agents like modafinil also have an impact, also are used in the treatment of those hibernation syndromes like atypical depression, where people curl up in bed, don't want to get up or get out of bed, can't concentrate. And antidepressants, the role of which are much more controversial, and we'll talk about in the next episode, where we talk more specifically about bipolar disorder and the use of mood stabilizers, obviously such as lamotrigine, because of its metabolic profile in situations where lithium is either not required or is contraindicated, or often as a first-line agent in young people. So, in developing a sequence of treatments, we know we can go from psychological and behavioral therapies through pharmacological therapies, and then looking to be able to develop an evidence base around other therapies, some like fish oils, which there's been quite a lot of interest, the use of modafinil, TMS, of which there are a lot of studies now ongoing, and other agents like ketamine, to understand how they impact on these sleep circadian systems and what is their role in treating these types of disorders. I'll just go on to finish off with the case that we saw previously, and just talking about some of the issues in her case. You were diagnosed with depression, is that right?
Yeah.
And can you tell me a bit about what treatment you had? What happened after that diagnosis was made?
So when I was 14, I was put on Zoloft, which worked fine for a few months, but then I kind of became numb and didn't feel any emotions other than anger and sadness. So I changed from that to something else. I don't quite remember what it was. But then I did see a psychologist up until I was probably I saw a psychologist from about 13 to 16. Yeah, it's probably about 16 when I stopped seeing her. And then I also have been seeing a psychiatrist ongoing.
And can you tell me a bit about what that therapy was like? Did things get better? Did they get worse?
I had like periods where it was great, but it was mostly talking about stuff, and I think that can only get you so far, because I was never really given any skills or any ways to make myself feel better. It was more just like talking about what was going on in my life, so it wasn't overly effective. But I would have times where I felt completely fine and where I felt great, and then I'd have other times where I felt like I just wanted to die.
Can you tell me a bit about the time before you initially came to see us at U-Space? Mm-hmm. Can you tell me what things were like when you came into our care?
So basically, first it was lockdown, and then both of my rabbits died from myxomatosis, which is basically a mosquito transmitted illness which kills them. It's like there's no cure, they just die. And one of them I was very, very close to. She was like my baby, so that was very painful. And especially having to bury both of them within the span of a week. That was extremely painful. One of them died in my arms, which is very traumatic. And
yeah.
so I think it was just one thing after another, and it just built up to where it just got to breaking point, like the straw that broke the camel's back. And one night I was making dinner and it just was not working out. And so I had to put down the knife, and then I blacked out, and I don't remember what I did. And then next thing I remember, I am like standing in the middle of the road. I'm trying to get hit by a car.
Wow. That's, pretty desperate.
Mm.
When you arrived at the hospital, can you describe what the assessment process was like? What was your experience of that like?
At the public or at U Space?
You can tell me a bit about arriving at the public hospital. What was that like?
I don't remember too much. I remember there was a lot of waiting around, and I didn't get in until about 1:30 in the morning. The food sucked. I would see a psychologist, I think once a day, and we would just kind of talk about next steps. Pretty much they would just be like, one of them told me I was chronically suicidal and then absolutely did nothing about it. And I was like, thanks. Anyway, so we discussed where I could go next, kind of what I needed. I think they were as helpful as they could be given what they had at their disposal, but yeah, it wasn't too good. And then I think I was there for 4 days, and then I went home for a couple weeks, and then I went to U Space, which I thought was it was already a very different environment. As soon as I got there, I made friends, which was great, because in the other ward I didn't really talk to anyone for 4 days, which was very lonely. It was a very good space for me. It was a lot more bright and open, and yeah, it was really good. I really enjoyed it a lot more there, and very thorough too. Found that I had gallstones, and I had them removed shortly after I left the hospital. Sorry, I'm getting another call. Sorry, that's never happened to me before.
Can I just take you back a little bit, because when you came to the hospital, we do quite a comprehensive multimodal assessment.
Yeah.
So we want to know a lot about your sleep. We want to know a lot about your energy patterns, your physical activity, your physical health. In addition to your mental health, we want to know about how you're coping with school, what your concentration is like, what your social interactions are like. What did that seem like compared to other kind of assessments that you had? Was it too much? What did it feel like?
No, I thought it was really good. I thought it was very thorough. It felt like they were really getting to the root of the problem rather than just skimming the surface like other places had done. And I got one of those sleep watches, so that was good, because sleep I was struggling with a lot with all the constant napping and tiredness. So yeah, I thought it was really, really good, just a very comprehensive, very thorough overall assessment of my health overall, like physical, mental, everything. It was really good.
Do you remember at the time what you felt your main problems were? What were the things that were causing you the most difficulty?
Probably the sleep and the kind of emotional dysregulation, where I would black out and basically just lose it. And then I would pretty much just like not be in control of my body. I remember one time I kicked a wall and almost broke my foot. It was fun. But yeah, so very, and like when I black out, I don't have any control over what I'm doing. So yeah. And that was a big problem. I've learned how to calm myself down from those now, and I can feel them starting. So now I can stop them before they get to that stage. Yeah. And that's been really valuable to me.
So if you think back to your goals, what were really bad when you got to the point where you were standing out in the middle of the road, and you think about what your goals were? What were your goals? What did you want to get out of treatment at that time?
I just wanted mood improvement. I think that was a big thing that I was really looking for, because I was just so low, and I was just so desperately sad after everything that happened. And yeah, I was looking for kind of just anything to just help me feel better. And I feel like I did get that. The care that I received was really beneficial to me. When I left, I felt a lot better than when I went in. So very valuable weeks that I spent in there. And the medication change has been really good. Yeah, my goals were really just to, you know, be able to stay awake during the day, just be able to manage my emotions, and just to not feel so desperately low all the time.
Do you feel that you were a participant in that process? Do you feel that your needs were, you know, taken into account, and that you were an active participant in planning the treatment?
Yeah, I feel like I was considered all the way through, and sometimes it was good because I didn't know what I needed, and I didn't know how, and if I did know what I needed, I didn't know how to go about it. So it was good that I was working with really, really experienced people who could tell me, you probably need to do this, and this is how you do it. But if I ever had anything where I disagreed or where I didn't want to go about it that way, then they would always listen and always say, yeah, we'll rather do it your way than force you to do something you don't want to do. Unless my way was a completely wrong way, and then I would take your advice.
So in that example, I think she highlights a whole range of things that were important to her. Her mood and anxiety symptoms, the fact that her sleep was very poor, she felt tired all of the time, she was really finding it hard to function, she had a lot of emotional dysregulation. But that the progression of her symptoms had brought her to a place where she really was not able to attend school, her concentration was very poor, and she had a lot of physical health problems, including hormonal problems, pain, and abdominal pain, and poor physical activity patterns. So in terms of her assessment and treatment planning, the things that we highlighted were CBT, DBT, optimizing her antidepressant, maybe down the track thinking of a mood stabilizer, looking at her sleep and activity patterns, using behavioral activation, using exercise, also light therapy, physical health assessment, the investigations and interventions that she required, metabolic screening that showed the insulin resistance, looking at interventions with diet, exercise, but also starting metformin, hormonal screening and assessment, which was for the assessment of polycystic ovarian syndrome, and then looking at the treatment and interventions for that, drug and alcohol assessment, minimization of alcohol, neurocognitive assessment, which showed significant deficits, cognitive deficits, and putting in place the appropriate educational support to help her successfully get through the Year 12 HSC process, looking at social communication skills, social relationships, looking at how that related to her interpersonal and social rhythms therapy, to be able to maximize her social participation in daily routines and the cognitive therapy associated with that. And very importantly for her, a family assessment, looking at psychoeducation and intervention. Often for parents, it's very hard for them to get the balance. How much do they push young people? Young people are often very irritable if you try and get them up and get them out of bed in the morning if you're a parent. So trying to explain to parents some of the fundamental biology behind these disorders and some of the strategies that are going to help young people to actually re-stabilize those systems over time without getting into conflict. Not an easy task. So in summary, we've highlighted some of the issues in circadian and bipolar type disorders, and around whether or not the illness type can be modified using environmental interventions like circadian-based therapies targeting sleep and activity patterns, and some of the pharmacological therapies that are specific to these disorders using melatonin analogs, and lithium. And those interventions specifically that reset or resynchronize or stabilize those circadian systems and make those systems less sensitive to repeated disruption that is likely to cause ongoing trouble in terms of people's health and well-being. Thank you very much for your attention. CPD points can be claimed for psychologists, psychiatrists, and other allied health workers and mental health nurses by contacting Grace Lee at Sydney University. As always, we would like to thank those people who support our research and so generously, including our partner Future Generation Global, which has been a major supporter of this work.